Welcome to another EduMed video, and in this video we'll be going through the next part of the Surviving Sepsis COVID-19 guidelines published on the 28th of March 2020. And in this section we'll be talking about the haemodynamic management of COVID-19 patients in critical care. This is a really interesting guidelines that was set up by a whole group of international intensivists and others, and was really here just to summarise the management of these patients. It hasn't been formally published in intensive care medicine yet, however you can access it online, and I've got the link in the description below. It's just a highlight from this slide that they looked at 36 experts from 12 countries, very similar to what they did with the Surviving Sepsis guidelines, where they tried to come up with consensus and a practical set of guidelines for the management of patients, in this case with COVID-19. They divided the recommendations up into strong recommendations and weak recommendations. What you will see is that the vast majority of the recommendations that are given are weak, and that's simply because we just do not know enough about this disease at this time in the pandemic. As time goes on, things will change, and obviously these guidelines might change. So it's always worth checking back to the link in the description below, and I will update the video as soon as there are big changes that happen within the guidelines. However, I think they're fairly robust and fairly sensible sets of guidelines, so I don't think there's much that will change from what's been published here. So in this part of the video, we'll be talking about the haemodynamic management of patients with COVID. I think one of the things that really struck most of us when we first started managing these patients is the fact that a lot of them were hemodynamically very stable. They needed very little or almost no hemodynamic support. And you can see that's reflected in the data that's been published, that between 1 and 35% of patients had evidence of shock. Now, the reason for that wide disparity could be partly relating to the time it took for patients to present to hospital, or also the phenotypes of the disease, or even the genotypes of the patients that are getting these. And we are starting to see a lot that different ethnic minorities may have increased susceptibility to severe COVID infection compared to others. It's all work in progress. But you can see here that from the Chinese data, that roughly 30% of them needed intensive care admission. Interestingly, you can see a few outliers like the Yang et al. Paper, which had 100% ITU admission. That's just the cohort they looked at. But you can see just the wide variety in the number of patients who presented with shock. And also the wide variety of those patients who actually ended up needing invasive ventilation. And it's difficult because we're not sure exactly how these groups of patients were taken, and it's probably heterogeneous groups that people are looking at in the different papers. What's also interesting is the cardiac injury biomarkers seem to have a wide variation. There were a lot of early papers coming out of China, especially talking about this odd myocarditis picture that was presenting. Now, at least in my practice and speaking to other UK intensivists, we haven't really been seeing that much of this COVID-related myocarditis. Some of the explanation for this might be the fact that we are seeing a lot of clots and a lot of patients presenting with PEs and microvascular thrombosis. Now, whether that in turn is causing a right ventricular strain pattern, and that's what's causing the troponin leak and potentially even the evidence of a right ventricular dilatation that might mimic a myocarditis, I'm not sure. But certainly we haven't seen as much of the myocarditis as the 23% at the higher end that was suggested in China. And especially the Wuhan data, where they suggest that almost 40% of patients died with potential myocarditis, and certainly that hasn't been the experience that we've had. Again, whether that's due to different ethnic groups behaving in different ways with this virus, the honest answer is we just don't know. But certainly shock doesn't appear to be a strong feature of this disease, and especially early in this disease. Now, the holy grail of good intensive care management is maintaining an adequate intravascular volume. So not having them overly full and not having them underhydrated. And there's a variety of different clinical parameters and different technologies that we use to try and assess cardiac output, intravascular volume, extravascular volume, and so on. I think quite usefully what the guidelines have suggested are very simple metrics that most intensivists can do in most intensive care departments. Now, of course, if you've got ready access to PICOs, LIDCOs, esophageal Dopplers, transthoracic impedance devices, all sorts of other things, TOEs, echoes, obviously we can be more nuanced in this. But I think for most people, what they've suggested is dynamic parameters in skin temperature, capillary refill time, and serial lactate measurements. And I think that's actually a really good guideline to take away. To be honest, most of the time when I'm using cardiac output monitoring devices, I'm confirming what I already kind of know by doing a clinical examination of the patient and looking at them. Now, I take that with a pinch of salt, because there is always observer bias, and also there's plenty of studies, especially in the anaesthetic literature, where by using goal-directed therapy with cardiac output monitoring, we dramatically reduce the amount of fluid we give patients in theatre at least. And one could argue the same could be true in intensive care. By having specific goals that we have for fluid replacement of patients, as opposed to just having random maintenance fluid regimes and random boluses of fluid, you can significantly reduce patients' morbidity and potentially mortality as well. There is suggested data that by reducing the amount of fluid you give patients, you can reduce mortality by quite significantly. And also you can reduce the amount of time that a patient stays in intensive care and the amount of time that they're on a mechanical ventilator. All of these things are good. Interestingly, they've put this as a weak recommendation, but I think when it comes to some of these guidelines, if you look at the risk versus benefit, there isn't really much risk in getting you to examine these patients appropriately and actually document and monitor the patient's capillary refill times both centrally and peripherally, taking into account, of course, the level of vasopressor therapy that they're on. The dynamic parameters that they've also suggested are things like stroke volume variation, pulse pressure variation, stroke volume changes, especially by giving fluid challenges, either in the sense of giving them IV fluid boluses or just raising their legs up and giving them an auto transfusion. There was a really interesting study that looking at serial lactates as opposed to looking at central venous oxygen saturations actually conferred better morbidity and mortality for patients when thinking about fluid resuscitation. Now, if you are looking at lactate, you have to understand that not every high lactate is related to hypoperfusion of tissues. Sometimes you can get a secondary hyperlactatemia. Anyone who's on a high level of noradrenaline or on things such as adrenaline infusions or salbutamol, either nebulized or intravenously, they can all artificially raise your lactate. And it's not necessarily related to an intravascular volume problem. They have suggested avoiding static parameters such as mean arterial pressures and central venous pressures as indicators for giving fluids. Now, anyone who's done any degree of anaesthesia, especially in the acutely bleeding patient or patients with liver transplants or cardiac transplants, central venous pressures can be quite useful when looking at specific patients and specific trends. So don't discount any of these things, but using them as a goal-directed therapy I think is wrong. So aiming for a CVP of 10 in patients is probably wrong, because there are a lot of other things that can affect your CVP, such as your intrathoracic pressure with things like PEEP, your abdominal pressure with things like ascites or bowel distension. So take all of these things with a pinch of salt. Look at the trend of any data that you're getting. Don't look at just a static number. And I think that's a very reasonable guideline to have. Now, they've suggested here for acute resuscitation of patients with COVID to use conservative fluid strategies. Now, I would suggest that in this day and age, we should all be using conservative fluid strategies. There's plenty of evidence out there that giving too much fluid, and especially unbalanced fluids like saline, can potentially cause quite significant harm to patients. So, what that means practically is giving 250 ml boluses of fluid, either by using a fluid pump or by using a 50 ml syringe. I think that's much better and gives a much better idea for you as the clinician looking after the patient whether they're fluid responsive or not. And bearing in mind there are different reasons for shock that aren't all related to hypovolemia. Based on general intensive care and anaesthesia data, we've suggested using crystalloids over colloids, and I think that's reasonable. And there's a lot of data about the potential risk of anaphylaxis with colloids. I think it's a bit overrated, to be honest, but there certainly are some patients who can develop anaphylaxis to colloids. And also just the physiology of using colloids, one has to be slightly careful of. In a septic patient with an inflammatory state, you can get endothelial leak and endothelial disruption. And in doing so, if you're using colloids, which can then extravasate into the perivascular space, you can then cause an increase in oncotic pressure in the perivascular space, and therefore make removing water at a later date and trying to reduce total lung water specifically later much more difficult. Now, fluid balance, the use of crystalloids and colloids in and of itself is a month's worth of lectures, so it's not something I'm going to go into now. But I think in general the use of crystalloids over colloids for most patients is absolutely reasonable. I'm not saying it's not worth giving colloids in certain cases, and I know that I certainly do in some resuscitative cases, but for the most part, crystalloids are probably adequate for you. And when using crystalloids, the buffered balanced crystalloids are probably better than the unbalanced things like saline. They use this as a weak recommendation because actually there's not a strong amount of evidence that saline is bad for patients. Certainly hyperchloremia does cause renal vessel dysfunction, can cause acute kidney injury, and can worsen a metabolic acidosis, which, if you've already got a respiratory acidosis from ventilatory failure, can make life a bit more difficult. But the reason they've left this as a weak recommendation is because if all you've got is saline, and there may be times where you run out of fluids because we just have that many critical care patients, saline is certainly not a bad option. I don't know of anyone who really uses the hydroxyethyl starches anymore, but if you do, I'd avoid it, and personally I've stopped using them years and years ago. And the gelatins, things like gelafusin, gelaplasma, again, they suggest against using it, and to be honest, for the most part, I don't know of many people who use it outside of anaesthesia. Certainly in critical care, for the most part, boluses of fluid are given using crystalloids. I think that's reasonable. Dextrans, again, not really used that much anymore, and certainly probably wouldn't use it, especially if you've got the balanced crystalloids. And interestingly, they've suggested against the use of routine albumin for resuscitation. It's based on a number of different studies, and to be honest, the use of albumin in intensive care is quite a complex issue and one that's far beyond this particular lecture. I think there is a role sometimes for the use of albumin as an acute resuscitative fluid. But for the most part, unless you're an intensive care consultant, I'd avoid using albumin, and certainly discuss it with your seniors or with other intensive care consultants before deciding to give a patient albumin. In terms of vasopressors, first-line vasopressor, as pretty much everywhere in intensive care, is noradrenaline or norepinephrine. It's actually not based on a lot of evidence, but we know that it works. We've got a lot of experience with it, and so as the first line, it's probably no bad thing. When noradrenaline is not available, they suggest vasopressin or epinephrine, so adrenaline, as first line agent over other vasoactive agents. I take slight issue with that. I think vasopressin is a very good drug and can be used, or its analogues can be used for vasoconstriction. Adrenaline, especially in low doses, and you've got to be very careful with how you give it, because very low doses of adrenaline actually cause vasodilation through its effects on the beta receptors. And it's only at slightly higher doses that it actually acts as a vasoconstrictor. It's very good at being a positive inotrope, but it causes a lot of tachycardia and potential arrhythmias. For anyone who does anesthesia, we quite routinely use things like metaraminol and phenylephrine infusions. Be a little careful of things like phenylephrine, because you can get tachyphylaxis. This is the condition whereby the body basically becomes too used to it, so you need to keep going up and up with the dose of phenylephrine. You get less of that with metaraminol. Metaraminol is a pure alpha agonist, and so it'll cause quite significant vasoconstriction, but it doesn't have the beta effects like noradrenaline does. But even though they've suggested against the use of metaraminol and phenylephrine, personally, before I go to adrenaline, I'd probably go to metaraminol as my next line. But they've suggested vasopressin or adrenaline. They've also suggested avoiding using dopamine, and to be honest, dopamine is a fantastic drug. We used it a huge amount years and years ago, but nowadays we have other drugs which are probably better. And certainly there was a Cochrane review in 2016 which suggested that there is an increased risk of arrhythmias with dopamine, although actually dopamine and noradrenaline in that paper there was no significant difference in terms of their vasopressor abilities and morbidity or mortality. There was an increased risk of arrhythmias, and anyone who's used a lot of dopamine knows that is the case. You do get more arrhythmias with that than you do with noradrenaline. And by varying the dose of the dopamine, there's theoretically things that you can preferentially give blood flow to, like people used to talk about renal doses of dopamine. I'll be honest, I'm not 100% sure that was physiologically what we were seeing, but it was a very versatile drug. But for the purpose of the COVID-19 pandemic, they've suggested against using it, and I'd agree with that. We've got better drugs out there. In those patients with vasoplegic shock, and I specifically say vasoplegic, i.e. they have a lack of vascular tone, and you've given high doses of noradrenaline, you do need to think about a second drug. What they've suggested is vasopressin as their second drug. And I think that's reasonable. And there's some papers suggesting that by adding in vasopressin rather than keep going up with the noradrenaline, you can reduce mortality. You can reduce the risk of arrhythmias like AF, and certainly we know that the higher the doses of vasopressor or inotrope that we use, the higher the risk of other side effects like arrhythmias from happening. But remember, vasopressin is quite potent and it can cause digital ischemia, and actually something I'm a little bit more afraid of is the gut ischemia that high doses of vasopressin can cause. So it should only be used for vasoplegic shock. Vasopressin shouldn't be used in hypovolemic patients. As with any vasopressing agent, you should always make sure that the patient is adequately volume replete intravascularly before you start increasing up things like noradrenaline, vasopressin, mataraminol, or phenylephrine. Now, there's a question as to what the best blood pressure target is for patients. And they've, in this guideline, suggested 60 to 65 rather than higher MAPs. And that's based on a couple of meta-analyses and the 65 trial, which is recently published. What they basically found in the RCT, with the meta-analysis of the two RCTs, was that low versus high MAP, they didn't really have any change in mortality or digital ischemia and so on. But what they did find is that there were more arrhythmias. The 65 trial, however, did show a reduction in death of about 3%. Now, if you look at the confidence intervals, it straddles 1, so even though that relative risk is reduced, it might not be significant. But they did postulate whether 60 to 65 is a better MAP target than higher ones, i.e. over 65. My slight proviso to that is I think it depends very much on the patient and on what you're doing to the patient. We certainly know that patients with, say, for example, brain injuries, where we want to try and maintain a higher mean arterial pressure to try and maintain a cerebral perfusion pressure that's adequate to counteract their raised intracranial pressure, we need higher MAPs. We've also got to think about the patients with coronary artery disease, and we were seeing that the patients at high risk of coming to intensive care with COVID-19 are those patients with comorbidities like diabetes, hypertension, coronary artery disease. For these patients, they may well need slightly higher diastolic pressures in order to improve their coronary blood flow. And something I often worry about is whether we're giving adequate perfusion pressures to patients with high intrathoracic pressures. So these are the patients on things like APRV with a P high of 30, 35, where the intrathoracic pressure is high. There's a high transmural pressure across the myocardium. What we need to make sure is that A, we're adequately perfusing the lung, and B, that we're adequately perfusing the heart in the intrathoracic volume. And sometimes that might mean that the patients need slightly higher MAP targets than the 60 to 65 that we've arbitrarily set. Similarly, patients who are chronically hypertensive may well need much higher MAP targets to adequately perfuse their kidneys. And certainly we see that sometimes in patients with renal transplants, for example, where the donor kidney may be from a hypertensive patient, where the moment we increase up the perfusion pressure, suddenly the donor kidney starts to produce urine. And the same is probably true with native kidneys in critically unwell patients. So, although I think it's a reasonable starting point to aim for 60 to 65, I think we do have to adjust it depending upon the patient and thinking a little bit about whether there's signs of ischemia on the ECG, whether they're developing AKIs, whether their urine output's dropping, and then adjusting the MAP target based on the individual patient. And I think blood pressure is such a variable thing across populations. Having an arbitrary MAP of 60 to 65 I think is difficult to justify, and I think that's the reason why they've talked about it having a weak recommendation. And the honest answer is I think we've just got to manage each patient's MAP target individualized for that particular patient by looking at them at the end of the bed and managing all of their organ dysfunction indices. In those patients with a lack of inotropy, so cardiac dysfunction and persistent hypoperfusion, what they've suggested is dobutamine, and I think that's reasonable. There are other options, obviously, but dobutamine's a pretty good standard one to go for, and it's good in most patients. One does need to be slightly careful of the tachycardia it causes, but to be honest, tachycardia in a failing ventricle, as long as you're not ischemic, it's probably not a bad thing. You will increase your cardiac output by just increasing heart rate, if nothing else. If you're worried about myocardial oxygen demand, there are other things that you can use, such as levocimendin or milrinone, but especially levocimendin in septic patients, there was a recent paper in New England Journal that suggested maybe it's not a good idea. Honest truth is, I think any of these drugs are probably going to be okay. We're talking about extremes of physiology. Interestingly, for low-dose steroid therapy, they've suggested to use it over no corticosteroid therapy. And the specific treatment regime they've suggested is intravenously 200 milligrams administered as an infusion or as intermittent doses. And to be honest, just in terms of managing the number of pumps, infusion lines, most of us tend to use a 50 milligrams 6-hourly bolus dose. And if you look at the pharmacokinetics of how and dynamics of steroids, infusion versus bolus probably doesn't make any difference at these high doses. There's no evidence for COVID. And actually, the evidence for the use of steroids is slightly tenuous. It doesn't seem to increase or decrease morbidity or mortality, but it does seem to reduce the time of resolution of shock and the length of stay in intensive care. And so it's probably a useful thing. Now, as with any steroid, it will increase the risk of muscle wasting. It can potentially increase the risk of developing Addison's once it's stopped. It can cause electrolyte dysfunction, it can cause fluid retention, and of course it can cause immunosuppression, which in a patient with a rampant viral infection with no specific antidote or cure, it can be bad. So we've got to take it with, depending upon the patient, and the limit for when you start it, it's debatable and different people will start at different points. But ultimately, what they're suggesting here is that steroids are probably not a bad thing, and to use it as a shock reversal tool. And I think that goes in line with what most of us do with most intensive care patients who have noradrenaline refractory vasoplegic shock. So overall, I think the guidelines for the hemodynamic management of COVID-19 are pretty standard. It's pretty much what we do with every other critically unwell patient. We use balanced crystalloids. We give fluid boluses. We're not too liberal with the fluids that we give. We use noradrenaline as our first line and then vasopressin in second line. Dobutamine seems to be a good inotrope, and to be honest, that's just based on personal preference. There's no evidence. So if you did want to use another drug such as milrinone or dopexamine or levocimendin, there's probably no reason not to do so. MAP target of 60 to 65, like I say, is debatable. It's probably not a bad starting place, but do bear in mind that some patients do need higher MAPs, and you've got to really be at the end of the bed looking at these patients, looking at the numbers, looking at the patient to decide on what the best MAP target for that particular patient is. And don't forget about low-dose steroids. I think it's certainly useful in a certain group of patients who have refractory shock, who do need that little bit of additional steroid to increase their vasopressor effects of noradrenaline. In the next section, we'll be talking about the ventilatory strategies of patients with COVID-19. And then the final video that we'll be doing will be the recommendations of COVID-specific treatments. Thank you very much, and I'll see you for the next video.